Well, hi everyone, and welcome to August. Welcome to Aging Well. We're so glad you're here. We have got an amazing program for you tonight, a very important program that our speaker is going to be talking about some very, very important steps that we all need to take in case anyone we know or ourselves could be thinking that maybe perhaps we're having a stroke. Very important, hit very close to home for me because of my mom. But anyway, we want to get started, and I want to tell you, Dawn and I, okay, Dawn, y'all know the truth. It was Dawn, decided to try out the Eating Well recipe this weekend. And I will tell you, it is fabulous. But I will also tell you that the recipe itself does not talk about searing the halibut. So when you're watching the program tonight, pay special attention. I am going to reach back out to Chef Jeff Bacon, to ask him if we can include that in the recipe, but just be aware, pay attention to his cooking demo because it's not included in the recipe. But having said all of that, Jeff Bacon is the executive director of the Providence Program with Second Harvest Food Bank. And he was voted Winston-Salem's favorite chef for 2025. So other than leaving out one little tiny piece of the recipe, it was fabulous, and I think I'm encouraging everyone to make it because it is something that you can make and it is fabulous. So I'm going to quit talking and turn it over to Chef Jeff.
Hi everybody, I'm Jeff Bacon. I'm the Program Director, Vice President, Executive Director, and Executive Chef of the Providence Programs at Second Harvest Food Bank of Northwest North Carolina. I want to thank Deb Burkham for sticking with me until she could find a slot where I could cook this delicious food for you. But I'm really happy to be a part of Aging Well today. I'm going to show you one of my favorite recipes. This is a lovely fresh halibut dish. I love halibut. It's one of my favorite fish. It's always mild, it's always flaky, it's always delicious, and it's always forgiving. It's really easy to cook with because it doesn't get overly dry and it's not hard to handle like some fishes are. This is going to be full of flavor but also healthy at the same time. So we're going to dive right in and get started. So some of the ingredients I have may be stuff that you're a little bit tricky to find. The first one is a shallot. It's a little teeny onion. Most grocery stores have them. But if you can't find a shallot, just use a purple onion and cut it really small. That's going to be a key component of what we're doing. And both our spinach stuffing for this recipe as well as the fish itself. So I'm going to dice this shallot up really fine. And I have a little bit of garlic here that I minced up earlier. So that's going to be the foundation of our spinach, pine nut, and feta cheese stuffing that's going to go inside the halibut. So I'm going to go ahead and start sauteing that right now. I'm using a little sauce pot to do that rather than a saute pan, just because I'm going to kind of get the spinach to melt down. It'll start out a lot of spinach, and by the time it cooks, it'll be just a very teeny bit of spinach. I'll let those get hot, and they'll just cook until they're soft. And then I'll add the spinach, and of course season with a little bit of salt and pepper. Obviously, if you have sodium concerns, use less salt or no salt. It's delicious anyway. There is some natural salt that'll come from the feta cheese that is enough for a lot of people. That's sizzling up nicely. So the reason I cut the shallots so small is because garlic will burn if it is in the hot oil too long. This is extra virgin olive oil, by the way. So if the shallots are small enough, they both cook at the same rate and they'll both be done at the same time. If you're not able to cut the shallots quite small, then just cook them first and then add the garlic halfway through. All right. I'm going to move this off here and start putting the spinach in. So it's going to look like I'm putting gobs and gobs of spinach in. It's really almost a whole bag, grocery store size bag, but it'll melt down to next to nothing. If you've cooked fresh baby spinach before, you know that it gets really shrink really small really fast. There we go. And just a pinch of salt and pepper. I'm just moving this spinach around so that it all gets in the heat. I'm not going to cook it completely down to soft because it's going to continue to cook inside the halibut once we put that in the oven. This is really just sort of get the flavors melded, get the garlic and shallots mixed in. And then I'm going to just do a teeny splash of white wine. And a little squeeze of lemon. Lemon, citrus, wine are great ways to add flavor to any dish without adding really hardly any calories and certainly no sodium or anything else that might be unhealthy. So this is what the spinach looks like now, and I'm going to go ahead and add in the pine nuts and a little bit of the feta. The feta is going to melt into this and sort of bind it a little as the heat from the spinach kind of makes it melt down a little bit. And while that's just sort of sitting there on coast, we will do a little work with our fish here. Like I said, fresh halibut. So there's a couple ways to do this, and I'm going to show you both ways. You can make a little pocket in this that you will stuff the cheese and the spinach into, or maybe an easier way is to cut it into two thin pieces so that you can just sort of make a sandwich. You can have a piece of fish, the spinach stuffing, and then another piece of fish on top. That's a little easier technically to do. I'm going to show you both because one is obviously a little prettier than the other. So I'm just making a pocket most of the way through. You see how I put my hand on top to hold it in place, but I'm not in danger of cutting my hand because it's parallel to the knife. Same thing this way. I'm just going to go all the way through. And then I'm leaving that last little bit attached so we can just fold it back over. And then we're going to saute those in that same extra virgin olive oil and then finish it in the oven, in a nice hot oven. You want your oven to be 425, 450 even, because halibut cooks very quickly. You almost can't undercook it. And you'll put it in the oven. You want to get a little color on it. You don't want it to be like poached fish. You want it to have a little bit of browning on it. So that feta that we put in here is softened up nicely and kind of melded in with the spinach. So in both of these applications, I'm going to put one more piece of feta right on top of the fish. And in this one, I'm going to put a nice slice. You can do this with crumbles, but I get the whole pieces of feta so that I can get these nice slices. It's just a little easier to work with for me. You can see crumbles would be kind of everywhere if we did that. And then I'm going to put some of the spinach in here on top. That has spinach, shallots, garlic, the feta cheese, salt, pepper, and the pine nuts. You see that's kind of nice that way. On this one I'm going to actually hold it in my hand where the pouch is up. Tuck that in there nice and tight. So you can see, same idea, two slightly different presentations. So now we're just going to saute them nicely in this saute pan. You'll see this is a nice stainless coated saute pan. It is not non-stick. You could certainly use a non-stick. This is nice because it develops some extra flavors as the fish cooks in the pan. So we're going to make sure that the pan gets good and hot before we add the fish to it because you don't want it to stick, so that's essential. So you'll see the surface of the oil start to ripple a little bit. That's when you know it's about to smoke. Some things you want to wait for the smoke point for it to be super hot. We're ready to go in now at just that ripple level. We're going to season the outside of the fish just a little. And this is just salt and pepper, kosher salt and coarse ground pepper that I've mixed together ahead of time. Halibut is something that I would not say easily can find at the grocery store, but I checked today when I was shopping for it, and Whole Foods and Publix both had it. Certain Harris Teeters also have it fairly regularly. So you'll notice I'm letting this sizzle. I'm not messing with it. I'm not trying to move it. I'm not trying to get a spatula under it yet. You really, that's the main mistake people make cooking fish, is that they try to move it too fast. They think, oh, it just sticks all the time. I'm not going to try to get it because it's so hard to get it to not stick. It's because you're trying to move it too fast. As it cooks, you'll get a nice crust on the outside of the fish. That crust doesn't stick to the pan anywhere nearly as bad as the wet, fresh fish does. So once it's cooked, it releases. Steaks and chicken also do that, but fish, it's way more important that you do that because it's fragile. If it sticks at all, it'll pull apart. So you'll be able to kind of see that there is a crust forming on the edges there, and you'll be able to look at it from the side and see as it browns when it's time to flip it. So there is some of that that's just experience, but it's easy to use visual cues as well. And you can also experiment around a little bit, you know, see if it feels like it's releasing. It is starting to release, but it's not ready yet, so I'm going to give it a couple more minutes. So you may say, Chef, why not just use a non-stick pan and save yourself all that trouble? Well, you see at the end, I'm going to finish this off with a little wine and lemon juice and a little bit more shallot and a little bit more garlic, and that's going to make a nice little pan sauce that you can drizzle over the fish. It'll have more flavor in it. You can do that with a non-stick, but the fish flavor that sticks to this pan and releases when I use the wine, the liquid in the pan, that's going to make enough of a flavor difference that it's worth the extra effort. All right, so it's starting to release nicely. While that's finishing up, I'm going to do just a little bit more with the shallot. Actually, there's probably enough in here. So I'm just putting a little bit more garlic and shallot in there, right in with that olive oil that's already in there. Gonna let that sizzle just a little bit. Always fun to get a little flame. Now, if you were in a fancy French restaurant, they'd throw a big gob of butter in right now. We're not going to do that. There's a little bit of feta cheese that'll leak out of the stuffing that'll fill that up. And you'll get a little fat content that way. Awesome. So we're going to put this straight in a hot oven. And that needs to cook about 9 to 10 minutes in the oven. And it'll come out perfect and delicious. Come back in just a couple minutes as that cooks and we'll plate it up and show you what it looks like finished. Hi, the fish has been in the oven long enough that it's ready to be plated. So I'm going to bring it out, put it on the plate, show you both ways we added the stuffing, and then talk a little bit about our program here at Second Harvest Food Bank. Add a little bit more wine to it. If you don't drink wine, there's no reason that you can't cook with it. Alcohol evaporates twice as fast as other liquids, water. And so the first thing that evaporates away is the alcohol, and all that's left behind is the flavor compounds. So if you don't drink, it is really not there's no alcohol left after you've cooked it with it at high heat. The exception to that, is like cakes, rum cakes, where you're drenching it with rum after it's cooked. Then, of course, it does retain the alcohol. So you can see we got some nice color on these two pieces of fish. They really look very similar, the one that we laid over and the one that we stuffed the pocket in. You can see a little bit better presentation side with the one where we did the stuffing on the side. They both look nice, perfectly cooked. We're just going to swizzle this sauce around a little and just get a little drip of that. And see that color is from the pan, the fact that we use a regular pan instead of a non-stick. I'm garnishing it with a little chopped fresh tarragon. That is not something you have to do. I just think it goes well with this particular dish. I also have some microgreens that you can get at Publix or Whole Foods. This is called Rainbow Mix. It's a combination of pea shoots and baby radish. And then just for fun, I'm putting a flower on this one. Edible pansy. So, here at the Providence Programs of Second Harvest Food Bank, we have a 13-week culinary training program that specializes in helping people with barriers to employment get back into the workforce. But a lot of different types of people come to our classes. We may have somebody that has been struggling with the justice system right next to somebody that is a retiree that has a spotless criminal record and a spotless work history. Put them right together in the same kitchen, add sharp knives and fire, and see what happens. And usually miracles happen. Usually there's some awesome cross-pollination and mentoring that happens, and people learn a lot, not just about cooking and culinary techniques, but about each other. So it's a wonderful place. You can go to our website, providencews.org, and learn more about how to enroll in one of our many culinary training programs. I want to thank Deb Burkham for having me today for this wonderful opportunity, and I hope that you try this recipe at home. Au revoir.
Thank you, Jeff. It's always so fun to get to meet these chefs and really kind of watch them create these beautiful, beautiful meals. And I'm so grateful. And for our next segment, our Living Well segment, who I'm grateful to the most, other than the wonderful woman who hosted our tour, is one of you. It was an Aging Well participant who told me about Waterworks in Salisbury. She goes, if you haven't been down there, you have to. It's this phenomenal art exhibit, and it's just 40 miles down the road. And it is just exquisite. And so Anne Scott Clement of Waterworks Visual Arts Center is going to give us a tour, and it really is just a tiny taste of what is available at this free accredited art museum in Salisbury.
Works. We're so delighted to have you here today. So just to give you a little bit of history about Waterworks, we've just turned 66 years old. We are a nationally accredited art museum and one of 12 in the state of North Carolina. We are getting ready to have our reaccreditation in 2027, so we're thrilled to have y'all a part of this and a part of our celebration of 66 years. We're a little hidden gem in the state of North Carolina, but we love to welcome visitors, and I'm getting ready to take you on a tour of the current show that we have. And interestingly, we have had over nearly 70,000 visitors since last September come to see this show. We've had visitors from all 50 United States. We've had 12 countries and 6 continents have come to visit us. So we're very excited to welcome you here as well, and hopefully y'all can come down and visit us in person. The show that we're getting ready to see will end on August the 30th, so time is ticking, so we welcome you to come. Waterworks is open Monday through Saturday, 10 a.m. to 5 p.m., and admission is free. Accessibility is extremely important to us, and we wanted to maintain that for all walks of life to be able to come here and visit this show. Okay, well, welcome to the Modern Masterpieces exhibit. We are so fortunate to have a collection of 40 modern masterpieces to the likes of Chagall, Picasso, Monet, Renoir. There are 28 artists represented in the room here. We have 38 paintings and then 2 sculptures, and the sculptures are out in the hallway, which maybe we'll see in a little while. But we are so thrilled. Josie and Julian Robertson, this is their personal collection. This collection used to hang in their New York apartment. Julian Robertson was actually from Salisbury. He grew up here and has always remembered his town of Salisbury, and often was heard saying everybody should be from a small town just like Salisbury. He went on to make his fortune on Wall Street, and he and Josie, over their 38 years of marriage, collected all of these pieces of art. Now, it's said that Julian was not real up on collecting art when they first met, but because she loved it, he learned to love it. He was more of the numbers man, she was more of the artistic partner. So we've got about 100 years of art history represented in this collection, with the oldest piece here being this Monet here that was painted in 1877, and then the Gerard Richter, this abstract piece by Gerard Richter that was painted in 1989, this one right here. So it's an incredible collection in and itself. So the pieces are hung in what we call salon style, and this is very similarly the way it was hung in their New York apartment. So it was basically, you see how it's kind of stacked on the wall here. We have got it divided into categories. So thematically, we've got portraiture, we've got still life, we've got landscape, and then we have the abstraction pieces. So let's move on to the next exhibit, Boston Alley. Welcome to Boston Alley. This is a really incredible exhibition of black and white photographs that were taken in 1937 of a small black impoverished neighborhood that just sat 2.5 blocks from Waterworks. We are so grateful to Alex and Margaret Smoot who took these photographs. They had no idea at the time they were taking them that they were recording history in the making. This little neighborhood, Boston Alley, was raised 10 years after these photographs were taken, so it was raised in 1947. This little girl that's pictured here in this photograph, her name is Betty Lou Smith, and she was 8 years old when these photographs were taken. Betty Lou, after growing up, she went on to become a minister, and then when she was 69 years old, she wrote a memoir about growing up in Boston Alley. Now, we're thinking the neighborhood was gone by this time when she was writing this memoir, but she had such fond memories of this small community that she wanted to memorialize it. So the memoir that we have, we actually have the memoir. And what we did for this particular show is we took a little snippet of it and adapted it to do a little 3-minute presentation. When you're here, that you'll get to hear an actor is performing as her, but it gives you an insight to what the neighborhood was actually like and what day-to-day life was like. These photographs clearly the people are happy in the photographs. They're proud people. These photographers that came into the community were actually white. So for them to trust them to come in and take photographs of them is just remarkable. So Alex and Margaret both had to gain their trust to be able to capture them in these images. These photographs were taken over 3 consecutive Sundays. They were obviously, to me, I don't know this for sure, but I suspect that everybody had already gone to church. Everybody's dressed in their Sunday best. They've come home, they've shared a lunch together, family style, maybe potluck lunch. And then Alex and Margaret visited them in the afternoon, and they're just going about their normal Sunday afternoon, relaxing, telling stories, entertaining each other, playing, whatever, and they're just exquisite. There are actually 42 pieces in this collection. We have on exhibit 26 of the pieces, and this is actually one of the photographs here of the little shanties where they lived. There were 12 of them in the community, and among these 12 houses, 50 people lived. It's just remarkable. Most of the folks, the men worked for the railroad. A lot of the women were domestic help. There's a picture of Aunt Sarah that's over in the other room, who was considered the matriarch of the neighborhood. And she was fondly remembered by Betty Lou Smith as she worked like a man, but she loved like a mama. And that's just one of the sweetest things that you can say about someone. But she has a very stern look about her. And so if she was indeed the matriarch of the neighborhood, no one would have been doing anything that they shouldn't have been doing. But these photographs just exude love. They invite you into their community. And as you look at them, they're not posed portraits as one might think. They're just going about their daily activities, and he and Margaret captured them just beautifully, right in their own way. So this is Aunt Sarah. She was considered the matriarch of the neighborhood. She actually worked at the transfer shed, and that was hard work. That was men's work. And so she is lovingly remembered as working like a man, but loving like a mama. And she actually took Betty Lou Smith in because her parents had passed away, and so she actually raised Betty Lou. So we are just so fortunate to have these photographs. And interestingly, in addition to the memoir that Betty Lou wrote about Boston Alley, in 2016, she came and identified all of these photographs. So now we have even deeper historical context, and it's really lovely. We have on the little tags some of the folks that she refers to in the audio. We have their quotes here, so that goes along so you can kind of put the photographs with what she's talking about in the narrative. So welcome to Remembering Boston Alley. These paintings, these oil paintings, were inspired by the photographs that we just saw that Alex and Margaret Smoot took back in 1937. And Maria Hawk, this is actually a self-portrait of her. She's a living contemporary artist. And she, when she first saw the Boston Alley images, we often have them hanging upstairs, she asked me if I would allow her to paint them. She was so inspired by the beauty of them and the love of community that they exuded. And so we talked about it, and I said, sure, let's do that. And so we had planned that we would do an exhibition of her interpretation of the images brought to color through oil paints in fall of 2025. I'm saying fall of 2025, so that hasn't even happened yet. So when I learned that we were getting the modern masterpieces here, what do you show along with the modern masterpieces? I mean, what could you possibly show that would be that wouldn't be conflicting with it? So I thought, well, let's do this Boston Alley show because it has a historical significance to Salisbury. Julian was from Salisbury, but it's completely different, completely standalone, and a nice juxtaposition to the modern masterpieces in general. So I called Maria up on the phone, and I said, Maria, how are you coming along on those paintings? And she said, well, when do you need them by? And I said, well, do you think that you could have them ready by September? And she said, oh, that's pretty soon, but you know what? I love a deadline. So she had originally had 2.5 years to paint these, and she had started painting on them. And so she painted 47 pieces in a year's time. And here we have them hung beautifully in here, her interpretation of what Boston Alley was like. She loved these paintings so much that she referred to them as her children. And she hung that, as she finished them, that she would hang them in her studio. And she spent a lot of time researching the colors and the textures and the fabrics of the time of 1937. As you can see, the brown tones kind of represent the Piedmont area of North Carolina. It gives that nice richness of the color of the soil here, which is very red, clay soil. She is also a white artist, and so she spent time too working on the tones of the skin tones of the families, the children. Now remember, she only had a black and white image to go against, so she had to kind of bring that to life herself in her own interpretation of that, and I really think that she nailed it. This is one of my favorite paintings. There's actually a black and white image of this, but what's so beautiful about this is all these children sitting with maybe a mother, a friend, an aunt, all sitting along this porch. They're not looking at you. They're looking at something that's going on in the little neighborhood, but it's inviting you in to come and join me and sit down with me and have a conversation. And that's a beautiful part of this collection and the photographs in general. Maria is as I said, is a living contemporary artist. She's from Cary, North Carolina, and Maria, a little interesting tidbit about Maria, she did not start painting until she was 58 years old. She's 73 now, and she paints every day, and she had never painted a day in her life until she was 58. Also, when you come for your visit, you will also might want to see the rest of the facility. We actually are a teaching museum, so we have classes for students ages 18 months through adults. In our upstairs studios, we have a hand and wheel clay studio. We have a dark room, so we teach photography, both digital and black and white photography, and mixed media classes in the other studios. We have an art library, which is incredible if you have want to do some research on a particular artist or a piece of artwork that you might have in your collection. So we welcome you to come and enjoy and learn all there is about Waterworks. Thank you so much for having me today, and I look forward to seeing you soon.
It was such a fun experience going down to Salisbury and getting to experience this amazing museum. So thank you again so much for our tour. And now we have Dr. Cheryl Bushnell. She is a neurologist. She is a professor of neurology at Wake Forest University School of Medicine. And she's going to be talking to us about what to do if we or someone we're with should be having a stroke. And again, I said this is very personal to me because my mom actually had a stroke and I was the one who responded. And I had learned what to do and how quickly to do it. And that was the difference between her totally recovering and possibly not having recovered. So I'm excited to hear from Dr. Bushnell, and I'm going to turn it over to her now.
Thank you, Deb. It's really great to be here, and I'm looking forward to being able to share with all of you some insights into what a stroke is and more importantly, how to prevent it. And so I'm going to share my screen here, and assuming that people can see my screen. So
It looks good.
Okay, awesome. So I want to talk about, I have an objective slide here. So what is this? I hope that these are the things you're going to come away with at the end of this 30 minutes. Know what a stroke is, have a feeling for how common strokes are, how to recognize a stroke, what to do if you see one, and how are strokes treated these days, what happens after a stroke, what is the aftermath, and in terms of aging well, how to protect your brain from a stroke. So we're going to talk about prevention. So a stroke, as I'm sure many of you know, is actual brain damage that occurs from either a blood vessel clot or a rupture. And so the symptoms that come along with this brain damage depend on where that clot was or where the rupture was. And so that is what determines what a stroke symptom will look like. I've had a lot of patients who say, well, my stroke had this, I was weak on one side, and my neighbor had a stroke that involved dizziness or difficulty walking, but those are strokes in two different locations of the brain. So just saying someone had a stroke is a little bit of a heterogeneous description. And so a lot of times if someone tells me they've had a stroke, I'll ask, well, how did it affect you? And the other really important concept that I think people who've had a stroke learn right away is that one side of the brain controls the opposite side of the body. So if you have damage on the left side of your brain, it's going to affect your right side. And what I'm showing you here are some images. So this is an MRI scan. And it's showing you two different sequences of the same person and who's had a stroke. And it's showing you the most common type, which is an ischemic stroke. So this is related to a blood clot. Ischemia is a lack of blood flow and oxygen. And so that's why we call it an ischemic stroke. And 85% of all strokes are probably going to be like this one in terms of how it happened. But again, the symptoms depend on the region that's affected. So in this particular case, we're looking at this abnormal part of the image here. It is it's actually on the left side of this person's brain, the right side of this picture. And so similarly over here, just two different sequences of the same thing. Now this is the left hemisphere, which controls language. This is the dominant hemisphere. So I would imagine that this person not only had weakness on the right side, but had a lot of difficulty speaking because the language center is about right here. So, so these are just, kind of an example of the different brain regions that could be affected in an individual. Now, this is a CT scan showing you what the stroke looks like on this particular type of sequence. Not as detailed as the MRI, but you can see this shows up dark, and on the MRI it showed up light. And so this is an evidence of a very large stroke that's affecting multiple blood vessel territories. And again, this darkness here is the damage that occurs from lack of blood flow and oxygen. So the other type of stroke is one that we call hemorrhagic stroke. This is related to rupture of a blood vessel, and it's less common, thankfully, only 15% of all strokes, but it is deadly. The mortality rate from these types of strokes is on the order of 40 to 50%. And if they don't pass away from the stroke, they often have very significant lasting effects. So an intracerebral hemorrhage is what's depicted right here, and that is bursting of a blood vessel within the brain. And this is an example of that on a CT scan. So it looks bright on CT scan. And then subarachnoid hemorrhage is blood that's within the lining of the brain. And so this is also a very, very high mortality type of stroke, and it can often affect younger people. I'm not going to really talk about subdural and epidural hematomas. These are often related to trauma. And so what we're talking about here is two different types of bleeding that occur spontaneously, often without any kind of head injury whatsoever. So how common is a stroke? Well, in the US, about 800,000 people experience a stroke every year. And what's really, really important is that about 25% of them, or 185,000, have actually had a second stroke. So these are recurrent strokes. And then globally, stroke is the second most common cause of death, and the third leading cause of death and disability among what we call non-communicable diseases. So these are not related to infections. So there are 12 million strokes in the world every year, 7 million deaths from a stroke every year, 94 million people living with stroke consequences. And this is just a really stunning example of how common it is. 1 in 4 people will experience a stroke in their lifetime. And it causes a huge burden, as I mentioned, but 1 of every 21 deaths in the US are from a stroke, and every 40 seconds someone has a stroke. And the lifetime risk has actually increased over time from 1990 to 2016. So it's up to 25% lifetime risk. And this is mostly US numbers, but again, just kind of giving you a feel for how common this is. And this is just a graphic showing you kind of what I've just told you on this previous slide in text form, that it's the second leading cause of death, the third leading cause of death and disability, the numbers of people affected here. You can see what some of the numbers are in countries around the world. I think it's important to note that a lot of strokes occur in people under the age of 70, and low and middle income countries bear the largest burden of stroke. And it's also the hardest to track and hardest to implement new interventions in those countries, especially if it requires a lot of technology. So this is just giving you a sense for some of the modifiable risk factors, and we are going to go through all of these in detail. First, I want to talk about how a stroke can affect people and how you can recognize it if you happen to be with someone who's having some of these symptoms. So I mentioned some of the symptoms at the beginning, but this is a mnemonic that we think is really helpful. It's called Be Fast. The B stands for balance, and this can occur in strokes in the back of the brain that affect your ability to walk, to have coordination, can also cause headaches. And then for E is eyes. You can have blurred vision. You can have loss of vision in one eye. You can have a stroke to your eye, and all you have is the loss of vision. You can have loss of vision on one side of both eyes, and that is affecting the part of the brain that controls vision. So that's why it's important to really understand if someone's having visual effects, and you can have double vision as well. The F stands for face. One side of the face is drooping. The A stands for arm or leg weakness, but you have someone hold up their arms. If one of them cannot be moved at all, or if it drifts down because of weakness, that's another sign. And then speech difficulty. So people who have difficulty with slurring their speech, or they're having difficulty getting words out, or understanding what someone is telling them. And then finally, the T stands for time. This is time to call for an ambulance. It's also tracking the time that the person was last normal. We use this to be able to figure out whether we can treat people or not when they get to the emergency department. So one thing I'll mention here is that the face and the arm weakness will typically be on the same side. So that kind of helps you put together symptoms that might be a stroke as well. Not always the case, but most of the time, those will be on the same side. So that is kind of the most straightforward, and it really does encompass the majority of stroke symptoms in this one Be Fast mnemonic. So what to do? Call 911. This is kind of what the T stands for in Be Fast, to call 911, because if you are brought to the emergency department by emergency medical services or an ambulance, you will get treated faster. You go to the front of the line, you get triaged by the emergency department personnel, and you get back into back into the bay where you can get evaluated and get treated potentially. So we think of time as brain. Every minute that goes by without blood flow, 2 million brain cells die. So this is why we are so focused on time and evaluating people quickly. These life-saving treatments are available only if the symptoms are recognized and people are seen by the appropriate emergency personnel. We don't, in the US, have a common, well, at least not in Winston-Salem. We can't give the clot busting treatment in the field, but there are some places that have mobile stroke units where they are doing that. They can get the CT scan, they have a CT scan on the ambulance, and they can actually figure out what type of stroke it is, and hopefully get all the blood work that they need also in the ambulance. And if everything looks favorable, they can get the treatment right then and there. But I want to also talk about what the treatment is. Thrombolysis is the clot busting mechanism. Lysis means to break up the clot. These are two different medicines that are FDA approved for treating a stroke, and they have to be given within 4.5 hours of onset or 4.5 hours of last known well. So if somebody went for a nap at 1 p.m., they woke up at 3 p.m. with these symptoms of a stroke, their last known normal is when they went to sleep and they were truly normal. So the stroke may have happened at some point while they were asleep. And that is not unusual. We see wake-up strokes a lot. So the two different medicines are Alteplase or TPA or Tenecteplase or TNK. And both of these can be given in the emergency department after we've gone through a checklist to determine that it's safe and they meet the criteria. And they have to look like they're having a stroke, obviously. Now, our other way of treating strokes is with a surgical technique called thrombectomy. And this is basically using a catheter, going up to the clot and pulling it out. And this can restore blood flow. It can have an amazing impact on improving lives and improving outcomes. So this is a CT angiogram, and you can see this blood vessel goes out here on the left-hand side. Here's the right-hand side, and look, there's no blood flow here. So this is clear evidence of what we call a large vessel occlusion. So this is a clot that's sitting right here. And then we can look at other imaging to determine how big the stroke might be. And so the pink is the area that's already damaged. The green is the part of the brain that's at risk. And so we use this information to determine whether somebody would be a candidate for this clot retrieval, where they can pull the clot right out of the blood vessel and restore blood flow. So outcomes after stroke are, again, depending on how big the stroke was, how big the clot was, how big the rupture was, if it's a hemorrhagic stroke. And the stroke is really one of the leading causes of serious and long-term disability. And only 50 to 70% of people with a stroke regain their functional independence. So definitely not 100%. And more than 20% are institutionalized within 3 months. So, and people die from a stroke every year. These are data from the World Stroke Organization. Over 7,000 people, or 7 million people, the crude death rate, 92 per 100,000. 52% of all stroke deaths are men, 48% women, and then 89% of the stroke burden is from lower and middle income countries, which I mentioned before on that graphic. And then, just to think about how many, it's not just that you are living with a stroke, but what are the people having to do to take care of this person? Loved ones have to stop their jobs. There's a lot of consequences and healthy life lost as a result of strokes. And a lot of times it's the most devastating if it happens to someone in the prime of their life. So how to prevent a stroke? Almost 80% of strokes can be preventable by these key 5 risk factors and lifestyle behaviors: high blood pressure, cigarette smoking, abdominal obesity, so fat that's around your middle, unhealthy diet, and lack of physical activity. And the American Heart Association advises to use 8 health factors and behaviors that can reduce the risk of cardiovascular disease and stroke. So in addition to the above 5, you add diabetes, cholesterol, and sleep, and you get life's essential 8, which is something that the American Heart Association is promoting to try to improve health and make sure that people can prevent a stroke or heart attack. So this is the bad news that, if you look at the green line here and the green shading, this is stroke, and you can see how much it's going to increase between now and 2050. And this is also just kind of the same thing, but in numbers. So you're seeing how many millions of strokes are going to occur. And it's only number 3 behind total cardiovascular disease and heart disease here in orange. So stroke is number 3. And then the other thing I want to point out, same thing as far as forecasting, it doesn't matter what age you are or what your ethnic background is. Everybody is likely to have, in every group, is likely to have an increase in stroke over the next 30 years. So it's not any one group that's protected. Everyone can be affected by this increase in what we expect to see over the next 30 years. So that's why we want to focus on prevention. It's key to protecting your brain from a stroke. And the same strategies for stroke prevention, importantly, can help you prevent dementia as well. So I'm going to go through the primary prevention of stroke guidelines as it pertains to life's essential 8, which is, focusing on heart and brain health. And so I was really fortunate to be the writing group chair of the primary prevention guidelines. And these are for practitioners and clinicians, but I think it's important for everyone to know that your doctor really should be screening for heart disease and stroke risk at least every 1 to 5 years. And that's in people who are 40 to 79. But in people who are age 18 or more, so like all adults, you should always be screening for these behaviors and medical conditions that increase the risk. And then the final screening recommendation is for social determinants of health, because these are the kinds of living conditions, things that are where people live, where they work, and what they do in their free time. This is what can really influence the risk of a stroke. And I just, as an example, people who live in a neighborhood where there's no place to walk. So we call that a neighborhood factor of their social determinants of health. So that can be a major factor for stroke risk as well. So diet, you just saw this beautiful halibut with spinach and feta it made my mouth water. We just had halibut the other night. But again, a diet is so critical for stroke prevention. A Mediterranean diet is what we recommend based on the studies that have been done. And then we also recommend salt substitution for people, especially those who have high blood pressure, because salt can influence the risk of increasing your blood pressure. We recommend screening for physical activity, 75 minutes of vigorous or 150 minutes of moderate intensity physical activity. And we also, as clinicians, are going to recommend that people avoid excessive time in sedentary behavior when they're awake. And this is really important. The data from this is convincing that if you can get up and move around and not just sit like a couch potato for hours at a time, it can really improve your risk of having a stroke or a heart attack. So just something to think about. And the beauty of Apple Watches, right? They ping you when you need to get up for at least 1 minute during that hour. Blood sugar, so people with diabetes, we are recommending if they have a high risk for heart disease or stroke that they're treated with GLP-1 receptor and agonists. These are the Ozempic and Wegovy type drugs, and this is something that you need to talk to your doctor about. And then I'm going to go to weight and obesity. So screening for someone's weight and whether they're obese or not is very important. And we have classifications of obesity that we use, and you can see down here, class 2 is a body mass index of greater than 35 and less than 40. And so even when you go to the doctor and you get weighed and they check your height, they're getting your body mass index, if you didn't already know that. And so it's helpful to know that a body mass index of less than 30 is what you really want to kind of strive for. And then in blood pressure is so important, the most modifiable risk factor for a stroke. Screening for high blood pressure, if you do have high blood pressure, to keep it under 130/80. Even lower than that is better. And then just if you have high blood pressure, we are often going to more than one medication, because 2 different medications working on 2 different mechanisms of blood pressure can be really effective, and then you can keep the dose lower. Obviously, smoking is a huge risk factor for stroke as well as cancer and heart disease, and so we obviously recommend that people stop. And then sleep, we don't have a lot of good information about sleep apnea or what the ideal sleep duration is, but we think it's somewhere between 6 to 8 hours. It's just not the kind of data that we have that we could put into the guideline yet. Now, I'm going to talk at the end here about the brain care score. This is all of the same things that I just mentioned that the American Heart Association emphasizes. They put a score to it. They look at some of these things you can self-administer. It looks at alcohol. That's not part of the American Heart Association. And of course, sleep is in the American Heart. But I just want to emphasize the social and emotional aspects of brain health. And so this is also part of the score that we know is actually really important. And if you look at the scores, you have a low score, that's the red line, that means you're the highest risk, and you can see how well that score predicts stroke and dementia compared to the people with the lowest, with the highest score, which is the good score. So this is good brain health down here. If you have something close to 21 in this version of the scale. Now, the other thing I want to mention is that if we can actually make progress on high blood pressure, diabetes, and obesity, if we reduce it by 10% and we get overall risk control increased by 20%, look at what we can do. We can reduce the risk of stroke events in the world by almost 15%. Now, if we're really aggressive and meet other targets that are even more healthy, we can actually get to somewhere between 35 and 40% reduction in the risk of cardiovascular disease and stroke. I think that's really important to think about. We can make great progress here. So the take home I have for you all is that there's a mnemonic to identify the clinical signs and symptoms called Be Fast. We have to act quickly because time is brain, and all those brain cells are dying as the longer the part of the brain goes without blood pressure or without blood flow and oxygen. Stroke is common. It will probably double by the year 2050 if we don't do anything. The good news is that 60% of strokes are preventable and 40% of dementia is preventable. And we really want to emphasize surviving stroke-free because the disability from a stroke and the years of life and productivity that are lost, you can't get them back. So it's always better to prevent it. So that ends my portion of this. More than happy to answer questions, and I hope this was informative for everybody.
Well, I certainly thank you. And I know a couple people have raised their hands. So if you could put your question in the chat, that would be wonderful. And that way Dr. Bushnell can answer them. I see we already have a question. So what are mini strokes?
That's a great question. We refer to mini strokes as TIAs, so transient ischemic attacks. They look just like a stroke, but they don't last long, and often may only last for 5 minutes to 30 minutes is probably the most common length of time. But the bottom line for a mini stroke or TIA is that there's no damage that we can see. When we do an MRI scan or a CT scan, we see no damage. And the good news is that all the symptoms are gone as well. But there is a high risk of stroke within 30 days of having a mini stroke. So we do act on that, and it is beneficial to be seen very quickly so that we can understand what the cause might have been. We can assess risk factors and start medications that could help prevent an actual stroke from happening in the next 30 days.
Well, that is alarming. I have heard about mini strokes, and I was wondering if that did increase your odds to having a major stroke, or what about
Absolutely.
people that have had multiple mini strokes?
Yeah, I mean, obviously that is alarming too. And so it is important to act on it, to be evaluated by somebody who understands what the options are for treatment, for what tests to order, what the risk factors are.
Well, to me, we collectively living here are so fortunate to live in an environment where we have access to all of this knowledge, all this information. And, it certainly changed my life hearing this over and over again, where it's not just a PSA on TV, but it's something that has become a fabric of who I am now. And I'm grateful for it. I'm extremely grateful that we live here. And so, how do you test for the mini stroke if there aren't any symptoms? Is another question.
There are symptoms, they just don't last long. So they like I said, they can look just like a stroke. And so that's the bottom line.
Okay.
Is yeah, so it could be loss of vision in one eye, and that could come and go. It could be weakness of the face, arm, and leg that lasts for 30 minutes, or any amount of time between 5 minutes or hours. So it looks just like a stroke. You just get better, and all those symptoms go away.
I've heard and I've continued to read that, and this is within the world of if I think I'm having a heart attack, but I think this would translate to if I think I'm having a stroke. And I think this is important too, that when you've called 911, also turn on a porch light and make sure your front door is unlocked so the medical emergency responders can get to you.
Mm-hmm.
And
Yeah.
to me, that's just very logical, but I don't know that I would have thought about that had I not been told.
Mm-hmm. Very, very good advice. Yeah.
Well, the good news for all of our attendees is that Dr. Bushnell is sharing her slides, so we will have all of that as follow-up information. And if questions continue to come in, I'm certainly delighted to forward those on to get responses for you, because that's to me the value of attending the live Aging Well events. Again, I thank everybody, mostly you, for being here with us in August. And hopefully, we're going to be experiencing a little bit cooler weather soon. But for September 9th, be right here because we've got some more amazing presentations to share with you and as well as some follow-up information of some lessons we've learned at the international level. So without further ado, I will bid you a good evening and hope you continue to live well and mostly age well, because we got to be around. I've got to be around I'm just hitting my prime. So come and join me.